So ultrasound assessment of the pyloric stenosis involves an understanding of firstly the pyloric anatomy and the ultrasound diagnostic signs and criteria. So this condition of hypertrophy of the muscle wall either side of the pyloric valve, which is where the stomach empties, is progressive, and it usually occurs in infants up to the 8-week mark. It's rare to have it in an infant older than that. So we need to be aware of what layer is the muscular layer. So this is the muscularis propria from here to here. It's hypoechoic. We want it to be less than 3 millimeters, but of course it's a progressive condition, so there may be measurements that fall into the grey zone when we're performing the assessment. So this muscle undergoes hypertrophy, which in turn causes compression of the lumen, which is from here to here, which means that the stomach contents can't enter the duodenum. So this can lead to gastric outlet obstruction. So the contents remain within the stomach and the infant tends to vomit more frequently. As it progresses, because they can't empty their stomach, they vomit and consequently feel hungry all the time and can tend to start to lose weight. Vomiting, by definition, doesn't have to be projectile to be indicative of hypertrophic pyloric stenosis. So the criteria. So the pyloric muscle thickness must be greater than 3 millimeters and remain that way throughout the entire examination. So that would be from here to here. So this is the serosal layer or the outer, and from here to here. So the canal length, it's abnormal from here to here if it's greater than 16 or 17. Literature reports cutoffs of 16 or 17. Diameter is reported in literature, so total diameter. However, that's going to change as the pylorus either peristalses and contracts, or whether it's opening and expanding. So that measurement can be quite unreliable. So the length of the pyloric muscle can also change during our real-time examinations. So the most indicative marker is definitely the muscular wall thickness. As it compresses the lumen, the stomach tries harder and harder to expel its contents, and hence we might observe hyperperistalsis in the stomach. The other signs I'll show you pictures of in a minute, which is the prolapsed mucosa into the gastric antrum, or what they call the antral nipple sign, and then trapped fluid within the crevices of the mucosa. They call this the double track sign, and that's reported by Huang. But it's one of those things that you may or may not see. It's not necessarily criteria. So we fast the infants for up to 3 hours. It's ideal that we get an opportunity to see where the stomach has actually emptied. So children with the severe HPS will have a full stomach when we commence the examination because it hasn't emptied. So here's a normal pylorus over here. Here we can see an abnormal muscularis hypertrophy, and stomach contents haven't been able to exit through the lumen, and this is the little nipple sign. We'll show you the technique in a video rather than me talk through this slide. There's multiple approaches which you'll see in the video, but in terms of assessment, we would use something like a linear 12 to 5 megahertz transducer. The pylorus is obviously medial to the gallbladder. If you place your probe somewhere up near the xiphisternum or the heart, you're in a good place to sort of be above the gas shadow from your hepatic flexure and transverse colon. So what and how do we measure? So if we're measuring the length of the pyloric canal, we would go from this little angle here, so where the stomach goes from wide and then narrows down, that's the end of the gastric antrum, along to this point here, which is where the pylorus then changes direction and becomes the duodenum, part 1 of the duodenum. So we're above the pancreas and anterior to the pancreas, and just immediately posterior to the liver. This is the falciform ligament, obviously over to the right of the screen. If we moved any higher, we'd be on the esophagus. So you're right in the midline of the infant's costal margins. The normal length is usually less than 16 millimeters, but as I said, some people use 17. The lumen, because it can contain gas, is often echogenic, and the mucosa is echogenic. So this is a closed lumen that's occurring because a normal contraction is occurring, which is falsely thickening this muscularis propria layer, which is why we say it has to be greater than 3 millimeters for the entire examination. It can't just be a transient thickening, because that would be normal. When the pylorus is open, we can see gas and sometimes milk and contents move through the lumen. It usually means that the posterior wall of the pylorus is greyed out. So what we're seeing is a longitudinal image of the bowel. It looks pretty much like a small bowel, really, but we're in the transverse plane on the infant's abdomen. So this sort of dirty shadow here is typical of gas. That's one of our little markers of what we're looking for, but obviously we'll see a gas shadow in the transverse colon as well. Transverse colon's a very large diameter in comparison with the pylorus, so we just need to make sure we've followed the anatomy properly. So when you see this sort of a sign, this indicates a relaxed and functioning pylorus. This is completely normal. So you can capture a cine loop and try and demonstrate the movement or passage of contents through that pyloric valve. But I'll just warn you that in the early stages of pyloric stenosis, you may still have normal luminal emptying, but much less volume is getting through. So it's a progressive condition. Once the infant has had a feed for, a good latch on and 5 minutes feed, and they're starting to settle, we then roll the infant onto their right side, and that would naturally make the milk want to flow towards the liver, so through the pylorus. But this may not then be the ideal position to scan in. So you might want to roll them onto their right, mum's still holding them, just to let or encourage the contents to start emptying through the pylorus, and then you may move them back into a different position for the actual diagnostic images. Because as you can see, when they roll onto the right, the pylorus is now pointing deep away from the transducer, and obviously that makes our measurements of the wall very inaccurate. We always want to measure the wall when it's horizontal across our screen, which is at 90 degrees to our ultrasound beam. So you've really got to be patient with the examination. Make sure you wait 5 to 10 minutes before you start to measure, because the pyloric stenosis sort of relaxes and almost goes to sleep while the infant's been fasting. It takes a little while to wake it up. So you don't want to sort of start snapping your cine loops too early. This lower image is showing our lumen opening like a big funnel. And that appearance is constantly changing. So we need to watch it over a period of time. And that period of time is usually somewhere between 5 and 10 minutes. We need to also make sure that we don't measure the total diameter when the child is undergoing peristalsis and the pylorus is open, because naturally it's going to expand the overall diameter. So you would rotate into the transverse plane, wait for it to close before you measure the diameter. This is a positive case of pyloric stenosis. So we see these great big hypoechoic halo around the lumen, which is compressed. But even so, we're seeing it partially open from time to time. So an image like this is really diagnostic, because we can get our calipers and measure this muscularis propria layer, and it's definitely going to be over 3 millimeters. Ideally, we, don't always want to measure it side to side just because of beam width artifact. It can look a little fuzzy, but this is quite a nice image. You can see here we're using a curvilinear probe. It's a slightly higher frequency. It's on resolution mode. Sometimes that's necessary for the larger infants where we can't get the right depth. So a very deep stomach and deep pylorus might require that. So you can see the length of the pylorus is being measured, as well as the thickness of the hypoechoic wall. It's only 0.23, so within the normal range. About 2.5 millimeters, it's starting to hit that sort of grey zone area where if the symptoms continue and the infant continues to lose weight, it may be good to do a repeat ultrasound down the track. But you can see here the overall diameter is 1.5 centimetres, so technically sounds abnormal, but that's because the lumen is open. So that's the same patient. If you then scan them at a different point in time, they're undergoing a contraction. We measure the wall at 2.3. It sort of looks quite hypertrophy, doesn't it? And the lumen looks like there's no contents running through it. So if you capture an image like this, it may actually temporarily look a little bit suspicious. But we keep watching. This is the same patient. You can see the contraction occurring. It's peristalsing. Little wave of contraction comes along. So you keep watching, and eventually you work out, oh, okay, this is actually opening normally. The same patient again, just on a different probe. Here we can see the lumen. It now has gas and contents. And now the wall has returned to quite a thin diameter at this point in the video. I'll just go back a little so you can see. See here, the muscularis layer is quite thin, just depending on, which phase. If we go back to the start, it looks a little bit thick right at the start because it was just about to contract. So it's a dynamic study. When it's positive, it's really positive. This is obviously quite an advanced one. You can see the length is probably over 20 millimetres. The muscular layer is definitely over 3 millimetres. In the axial plane, we get this typical sort of target sign. This is from Radiopedia, just showing you how to measure the length, the diameter, and the wall thickness. But at Q-Scan, we're sort of more interested in this wall thickness rather than the diameter, just because of the amount of error that can be introduced from peristalsis. The antral nipple sign is basically when you get this redundant pyloric mucosa. Because of the squeeze here, it sort of bulges back into the antrum of the stomach, protrudes like this, so that's the little nipple sign. In this case here, it's a borderline case, which we'd probably do a follow-up in 2 to 4 weeks. So even though it's not hitting 3 millimetres, it's between 2 and 3 millimetres, this wall. So the diagnosis could be pyloric stenosis, but it's too early to say yet. So if you see this for, persisting for a good percentage of your examination time, which is, I say, 10 to 15 minutes, it can be helpful to use the word possible pylorospasm. And it's sort of a get out of jail card. It's by saying, well, physiologically it may be a spasm, it may not be something that's permanent and progressive, and in a day or two that it may have all relaxed and look normal. So by using this word pylorospasm and calling the infant back for a follow-up, we can ensure we don't miss any cases. In terms of additional signs, as I said, the gastric contents can seem to hyperperistalse. We can have contents remaining after the 3 hours. We fail to see the canal opening, or you might see it partially open with some contents passing through. And then there's the nipple sign and also what they call the cervix sign. So basically just looks like a cervix as a part of our gynae ultrasounds. I'm sure you're familiar with what cervixes look like. These are some abnormal cases. So target sign here, looks like a cervix here or a cucumber. And we can see the little prolapse of the mucosa back into the antrum here. Sort of the nipple sign, axial view there, big thick hypoechoic ring, and here's another abnormal case here. So you can see when it's clearly abnormal, it's not easy to miss that, not hard to miss that, sorry. So there's another type of vomiting which should really be managed within a children's hospital, and that's where the vomit is green. So bilious vomiting is not something that pyloric stenosis sufferers have. Bilious vomiting, or that green vomiting, is more to do with a gut obstruction, and it's quite urgent. So infants with non-bilious vomiting, yes, we can scan those within our departments, and ultrasound of the pyloric stenosis that's what we do. But when it's bilious vomiting, unless you're specially trained to look for mid-gut rotation, it's best to send these urgently on to the Children's Hospital. There's other pathologies we can look for. Meckel diverticulum, which is just like a little outpouch or a bulge off the small intestine, looks like an appendix. It can become inflamed just like an appendix. So children can't talk when they're pulling their knees up towards their stomach and vomiting. It can sometimes just be that they're in pain, so we can look for mesenteric adenitis or a mass on the kidneys or a mass in the liver, and we can look for intussusception just by getting a 12-5 transducer and lawn mowing up and down the abdomen, looking for anything suspicious. This midgut volvulus, that's the midgut obstruction that can lead to the bilious vomiting. So even if you can see the SMA and the SMV in a normal orientation, it's not always going to exclude the midgut volvulus and rotation. So just be aware of that just because they're normal, the twist or the rotation where the jejunum, which is normally in the left upper quadrant, flips down and into the right iliac fossa, it may occur below the level of the pancreas. So really it needs to be done by suitably trained sonographers. The jejunum has a very wrinkly pattern in the left upper quadrant. So when you look in the left upper quadrant, we want to see lots of wrinkles within the bowel. Mesenteric nodes look like this. We count the number and we look at the AP diameter. I'll show you a normal ileum now. So this is a normal ileum in the right iliac fossa with the probe in transverse. We're just lateral to the external iliac artery, and we're seeing the psoas. So when you see a small diameter piece of bowel, the peristalsis is a lot draping over and joining the cecum. If it's not blind ending, it's probably the terminal ileum. The wall should be really thin. We shouldn't really see the muscularis layer in a normal infant, and it should be peristalsing, so you'll see the contents moving from right to left across the screen quite frequently. This is an abnormal ileum in someone with Crohn's disease, so we can see how the muscular layers thickened up and then this echogenic thickening as well just inside. This is typical of Crohn's disease, which is more likely in your sort of juvenile age, but I think it's good to know about and read up on Crohn's disease. And then you've got normal jejunum, as I said, looks really, really wrinkly. So if you saw this pattern in the terminal ileum, they call that jejunization of the terminal ileum, and that can be a sign of Crohn's. Or if you see wrinkly bowel like this sitting down in the right iliac fossa, that could be a sign that this is rotated and twisted off the big mesentery. So you know how the SMA and SMV hang here from the pancreas, and then this bowel in the left upper quadrant just flips over and ends up down here, and that would be a midgut rotation. This is an intussusception. Okay, so this one's not obstructed, it's just moving in and out, so you can see a lumen within a lumen. Still all peristalsing freely, but this is sort of the leading edge here, so the length of the intussusception is quite short. Some of these you'll see transiently and you can just push them with the probe and they resolve spontaneously. So you can see the enveloping bowel in. So imagine you put a hand down a sock, the ankle part, all the way to the toe, pick up the toe and drag it back inside the ankle part of the sock. That's what an intussusception is. Here's another intussusception in axial view. So it looks like a target sign within a target sign. So circles within circles. So we've got one little bit of bowel enveloping inside the next little bit of bowel. And this is up in the left upper quadrant. So these are jejunal intussusceptions, and they rarely become a complication. So we can sometimes see these in an asymptomatic patient as well. But you can see in this case it's a little bit inflamed. So question is, does it resolve during your scan or is it persistent? So we definitely flag it in a child. This was a 6-year-old child. The other thing sometimes just to be aware of is the appendix is not always on the right. So this was a left adnexa scan showing the blind ending sac. It's just coming down the bowel in transverse, turning the corner, there's the blind end, completely wrong side of the body. So that's why we make sure our examination's nice and thorough. So there's the references, and I'll leave you now with the videos taken live at one of our tutorials. Thank you, bye. There's the pylorus. It's moving fast. So you can see it, it's now squeezing, panting away there. It's wide open. So there's nice passage of milk through the lumen. So what we did is we went up to the zippy sternum and followed the falciform ligament down from the left portal vein. And we're sort of nice and high, angling down as if we're looking for a pancreas. And there's a little pylorus there, so it's wide open. You can see the gastric antrum to the end, yep, and this is the total diameter, obviously inaccurate because it's wide open. And now it's contracting. It's a very nicely behaved baby. You can see now it's just gone into like a little contraction mode. So at this point, when it's peristalsing, the wall thickens up. And so now it's wide open again. So that valve is opening beautifully, and we've got great passage of fluid. So definitely no pyloric stenosis there. See, it's starting to peristalse again.
And what else? Is it just when it says career pyloric stenosis? Is there anything else?
Yeah, so if it's normal, I might, as a very bare minimum, do the kidneys. So you roll and do the kidneys. No, I do flick through the liver. So I go through the organs. So this is liver, angling up and sort of coming down. Obviously, yeah, but like the documentation's quite minimal. And then in longitudinal is the liver again. And then gallbladder. So you can do gallbladder, but now that Bub's eaten, it's contracted. And then obviously for kidneys, we'd roll them. You can do them like being nursed by mum, yeah, up against the chest.